Our next speaker is Cori Cook. She's an attorney and the founder of CMC Consulting, a boutique consulting and legal practice focused on providing specialized advisory and legal services to TPAs and others. Her expertise has been widely sought out by government and industry in the arena of healthcare and healthcare reform. She's a nationally known speaker, and we're very honored to have her with us today. Please help me welcome Cori Cook.
That might be a little overinflated, maybe. I know I'm going to start coughing, so I'm going to brought water with me. Thank you for the introduction, and thank you for having me here. I am honored to be here today. There's no place that I would rather be. The inaugural Free Market Medical Association conference, and this is fabulous, and it's just the beginning, and it's really going to take off. If you know me at all, you know that I'm a huge fan of transparency, a pain in the butt for regulators, PPOs, greedy providers, and service providers that do nothing more than tack on a fee for the illusion of value. The illusion of value, there is a lot of that going on, and there has been for years. I'm a big cheerleader for providers like Dr. Smith and Dr. Latier that are doing the right thing, and many of you in this room doing the right thing for the right reason. Thank you for doing what you do, and thank you for allowing me to be here today. I have shared the story of how I met Dr. Smith and Dr. Latier as I've traveled around the country speaking at conferences, and I would be remiss in not sharing it with you here today. For those that heard it several times by now, I'm sorry. And Keith, I'd like to say I promise I'll never say it again, but that's probably not going to happen. A couple of years ago, Steve and Keith were at a conference, the Society of Professional Benefit Administrators Conference. It was in Las Vegas that fall. And they were sitting on a panel, and my dear friend Robin Jacobson was the chair of the board at that time. She'd invited them to speak. And I was sitting in the audience, much like you are today, multitasking. I was kind of listening to what Dr. Smith had to say, kind of not thinking what we've heard many times today, this is too good to be true. And then all of a sudden, I heard Keith say something that caught my attention. And it was something along the lines of, I don't understand how physicians can take an oath, treat a patient, and then turn around and put their patient in medical bankruptcy. And my head lifted, and I thought to myself, he's not going to say that unless he means it. And if he means it, something has just changed today for me. The conference was set up much like this, and there were mics around the room. And when he was done presenting, I stood up and walked over to a mic in front of hundreds of my colleagues from all over the country, and I said, I don't know who you are, but I love you. And here we are today, and I know that many of you love him as well. That evening, a group of us went out to dinner, and I remember the night like it was yesterday. Steve reduced me to tears as we had an in-depth discussion of our mutual faith. And then I asked the question later on in the evening, could you please explain to me how much you're upcharging your implants? And they looked at me like I was speaking Greek. So I just kept speaking. Is it 200%? Is it 400%? Is it 600%? Because I've seen as high as 2,700%. But if you're not willing to put your patients in medical bankruptcy, you're probably not willing to upcharge 2,700%. So what's the magic number? And they looked at me and said, we don't. In fact, if it's below a certain amount, we don't even pass the cost on to the patient. But for those that we do, we actually pass on the actual cost. I mean, that's unheard of in this industry. That's what we do. My past experience as a COO and general counsel for a TPA, you get those large claims in, and that's the first thing you're doing if there's an implant, is seeing how much they've increased the cost of the implants. So here we are. We now have the Free Market Medical Association, an annual conference, a room full of like-minded people. Service providers, I believe, are here as well, employers, and I believe we have a few students, and I couldn't be happier. If you are not like-minded and you're sitting there as a skeptic multitasking, let's have a drink afterwards. Again, thank you for having me. Typically when I speak, unless I'm speaking with Dr. Smith, I am addressing regulations, and I usually have a framework to walk through. And so when I was preparing for this speech, I'm like, well, I don't want to talk about regulations. We do have the employer mandate that's going to be upon us in the next couple months. And the employer mandate on a Friday afternoon at 4 o'clock doesn't sound like that much fun. We can switch gears if you'd like, but maybe not. So I started kind of going through, I get Keith's blogs all the time, and he educates me on a lot of historical facts, and so I kind of put together a little story how did we end up where we are today? And do I have a clicker, or are you going to click? So here we are, Lewis and Clark. I'm a Montana girl, so my first slide. Let's go back to the 1800s. Payment schemes were based on a person's ability to pay. Physicians adjusted their fees, and bartering was common. Sometimes referred to as domestic medicine, and home remedies were abundant. It actually reminds me, I had forgotten about this until I was preparing for today. I had a great aunt, Inez, that was born premature. She was a little over a pound, and they told her family that you might as well just take her home. She's not going to live through the day. And her grandmother brought her home, and she put her in a shoebox and soaked cotton in vinegar and placed it on her and stuck her by the fireplace. And my great aunt Inez lived to be mid-70s and survived being a premature baby. It was a time when government left matters to states and states left them to the private and voluntary programs. And we slowly became an urbanized country. The American Medical Association was organized, and nursing became professionalized. We later added the company physician. The doctor was employed by the employer, typically cared for only those that were injured on the job, and there was one goal: return to work. Today we have many employer-sponsored plans across the country. My former employer, a large TPA based out of Montana with offices in Colorado and Oregon, started an on-site clinic in 2006 for their employees and their dependents that were covered under their health plan. Still going today, has been a huge success. The office visits were free. Maintenance medications were free. The goal was to remove the barriers for the employees that needed treatment. And if they needed medications that weren't maintenance meds, then they were given to them at cost. Well, I think it was Dr. Doug earlier mentioned that you said 6 states in the United States that don't allow physicians to dispense. At the time this was happening, there were 11, so a few of them have come to their senses. When I was trying to lobby that change in the state of Montana, you would have thought I was the devil. Physicians, apparently, you guys are dangerous, dangerous people, and you're trying to kill people. So don't ever try and dispense in the state of Montana. So we had to become a pharmacy, and when you really dig into the cost of medicine, there's another shocker for you that'll just upset you. So we became a pharmacy, we had a clinic, we had a medical director, and ironically, the medical director that we first hired for our on-site clinic was the grandson of the gentleman that was the on-site clinic for Sears back in the day when employer-sponsored health plans kind of first came about. Around that same time, we also added the contract physician. Today, concierge services, and we're kind of seeing versions of that in the room today. Before the 20th century, hospitals were places where folks went to die. Today, that's the nursing home. Hospitals were institutions of social welfare and charity, typically where religious orders met the needs of the needy. Welcome to the progressive era, early 20th century, working to improve social conditions for the working class. Labor and Socialist Party support for health insurance, or sickness funds, as they were referred to, and benefit programs were fragmented. In 1906, the American Association of Labor Legislation led a campaign for health insurance. In 1915, they drafted a model health insurance bill that would cover the working class and others that made less than $1,200 a year. Opponents, which included doctors, labor, insurance companies, and businesses, denounced the bill as socialist insurance. Excuse me. And with the U.S. entry into the World War I, the national insurance debate to achieve compulsory health care came to an end for the time being. Around this same time, the first example of an HMO formed. The Western Clinic in Tacoma, Washington began in 1910, offering through its own providers a broad range of medical services in return for a premium payment of 50 cents PEPM, available to lumber mill owners and employees, later expanding to 20 more sites. In 1929, right here in Oklahoma, Dr. Michael Shadid established the Rural Farmers Co-op plan in Elk City, Oklahoma. Participating farmers purchased shares for $50 each to raise capital for a new hospital. In return, they received medical care at a discount. No surprise, the medical community threw a fit. Dr. Shadd had lost his membership in the County Medical Society, and they threatened to take his medical license. Some 20 years later, he was vindicated through an out-of-court settlement in his favor of an antitrust suit against county and state medical societies. They'd had a field day with Dr. Smith. Then came the Great Depression, where the national focus was on feeding people, unemployment insurance, old age pensions, and in 1935, President Roosevelt signed the Social Security Act. As we all know, the act established a system of social welfare and social insurance programs. In the midst of the Great Depression, the Social Security Act omitted compulsory health insurance in favor of unemployment and benefits for seniors. Health insurance then became an industry. Health insurance was fairly new in 1929 when our dear friends at Baylor Hospital in Texas agreed to provide some 1,500 teachers with prepaid care at its hospital, an arrangement that represented the origins of Blue Cross. The formation of Blue Cross Blue Shield and the beginning of HMOs in the midst of the Great Depression came about not because consumers were demanding insurance against the risk of medical expenses or because entrepreneurs were starting new businesses. It came about because providers wanted to maintain and enhance patient revenues. The period surrounding World War II brought about several HMOs, some of which remain prominent today: Kaiser, Group Health. In 1939, the Wagner Health Act proposed a national health program funded by federal grants to states and administered by states. Both political parties opposed the bill, viewing it as a form of government expansion. In the 40s, the employers began providing employee health benefits in order to overcome wage and price controls that were set during World War II and to compete for workers, further decreasing an interest in the national insurance plan for U.S. workers. Although Truman and many others wanted a single-payer system, in 1946, Senator Harold Burton of Ohio and Senator Lister Hill of Alabama were instrumental in passing it was actually called the Hospital Survey and Construction Act, later referred to as the Hill-Burton Act. The act was designed to provide federal grants and guaranteed loans to improve physical plant of the nation's hospital system. Money was designated in the states to achieve 4.5 beds per 1,000 people. Facilities that received Hill-Burton funding had to adhere to several requirements. They were not allowed to discriminate. They were also required to provide a reasonable volume of free care each year for those residents in the facilities area who needed care but could not afford the care. Hospitals were initially required to provide uncompensated care for 20 years after receiving the funding from the act. The money was only provided where state and local municipalities were willing and able to match the federal grant or loan, so that the federal portion only accounted for 1/3, and the state and local municipalities were also required to prove the economic viability of the facility. Once Medicare and Medicaid came about, participation in those programs was added to the list of requirements. No surprise, the reality did not meet the written requirements of the law. There was no regulation to define what constituted a reasonable volume to ensure that hospitals were providing enough free care. Then the lawyers got involved in the 70s, and they began suing the hospitals for not abiding by the law. The act originally was scheduled to sunset in June of '73. It was extended at the 11th hour, and in 1975, the act was amended and became Title 16 of the Public Health Service Act, which has since added some regulatory and compliance components, one of which was converting the 20-year charity requirement into perpetuity. So it's a perpetual scam. In the 1960s, there was a growing need for health insurance for the elderly and those outside the workforce. And in 1965, President Johnson signs Medicare and Medicaid programs into law, providing comprehensive, low-cost health insurance coverage to millions of Americans in need. And we all know what that currently looks like, a tsunami of fraud. The 1970s brought about more HMOs, more battling health care proposals. HMOs played only a modest role in the financing and delivery of health care, and throughout the years of consolidations and mergers, they declined in numbers. The boost came in the 70s with the Federal HMO Act, which authorized the startup and funding of, more importantly, the access to employer-based plans. Also in the 70s, it's believed that the PPOs originated out of Denver at the initiation of Sam Jenkins, who worked for the Siegel Company. he began negotiating discounts with hospitals on behalf of Taft-Hartley plans. In 1971, President Nixon recognized the draining effects of healthcare costs on the economy and proposed universal healthcare, really the first attempt at the employer mandate. There were 20 different healthcare proposals introduced in Congress during Nixon's administration, and during this time, we were also introduced to ERISA and DRGs and other versions of managed care. In the 80s, we had Ronald Reagan, who opposed social health care, universal health care, publicly funded health care, all forms. In fact, in 1961, before he was the president, while still a member of the Democratic Party, he voiced his opposition to a single-payer system, and I have just a clip of his video that I'd like to share with you.
One of the traditional methods of imposing statism or socialism on a people has been by way of medicine. It's very easy to disguise a medical program as a humanitarian project. Most people are a little reluctant to oppose anything that suggests medical care for people who possibly can't afford it. Now, the American people, if you put it to them about socialized medicine and gave them a chance to choose, would unhesitatingly vote against it. We had an example of this under the Truman administration. It was proposed that we have a compulsory health insurance program for all people in the United States, and of course, the American people unhesitatingly rejected this. So, with the American people on record as not wanting socialized medicine, Congressman Farrand introduced the Farrand Bill. This was the idea that all people of Social Security age should be brought under a program of compulsory health insurance. Now, this would not only be our senior citizens, this would be the dependents and those who are disabled. This would be young people if they are dependents of someone eligible for Social Security. Now, Congressman Farrand brought the program out on that idea of just for that particular group of people. But Congressman Farrand was subscribing to this foot-in-the-door philosophy because he said, if we can only break through and get our foot inside the door, then we can expand the program after that. Walter Reuther said, it's no secret that the United Automobile Workers is officially on record as backing a program of national health insurance. And by national health insurance, he meant socialized medicine for every American. Well, let's see what the socialists themselves had to say about it. They say, once the Farrand Bill is passed, this nation will be provided with a mechanism for socialized medicine capable of indefinite expansion in every direction until it includes the entire population.
That was in 1961, folks, and we're still having the same conversations. In 1962 is when Ronald Reagan switched parties. Then came the Clintons. Doesn't that sound like an Adam Sandler movie? At times it was like an Adam Sandler movie. The Clinton Plan, AKA the Health Security Act of 1993, the goal was to come up with a comprehensive plan to provide universal health care for all Americans. Again, a core element was to have an employer mandate to provide health insurance coverage for all employees. We clearly have a theme going on here. During an economic boom in the mid-90s, there was a consolidation of payer companies, and by 2070, we were left with 4 commercial for-profit companies covering nearly 45% of all covered individuals, affectionately referred to as BUCA, Blues United, Cigna, and Aetna. Healthcare costs rising, economy softening, U.S. companies were being confronted with competition abroad. These forces led to the increase in cost sharing with consumers through higher payroll deductions or premiums and benefit changes through the various plan options. A highly dynamic system with roots of which are many, the continuing growth and evolution is affected by the health sector economy, marketplace needs, legal and regulatory requirements, changes in delivery, customers' demands, political and other forces that interact. No surprise to anyone in this room, the United States healthcare system is the most expensive in the world. Among 11 nations, the U.S. ranked last and has for several years. The U.S. fails to achieve better health outcomes, and we're at the bottom of the list for access, efficiency, and equity. Yet the other 10 countries spend considerably less on health care per person and as a percentage of GDP than we do. The U.S. healthcare system can surely improve in achieving value for the nation's substantial investment in health. So, what have we done lately? Obamacare and all that it entails. It is, in fact, a new day. And the best way for me to describe Obamacare to you, I can actually do it in one sentence, if you'll bear with me. And many of you may have already heard this. We have been gifted with a health care plan we are forced to purchase and find if we don't, which purportedly covers at least 10 million more people without adding a single new doctor, but provides for 16,000 new IRS agents, written by a committee whose chairman says he doesn't understand it, passed by a Congress that didn't read it but exempted themselves from it, signed by a president who smokes, with funding administered by a Treasury chief who didn't pay his taxes, for which will be taxed for 4 years before any benefits take effect, by a government which has already bankrupted Social Security and Medicare, all to be overseen by a Surgeon General who's obese and financed by a country that's broke. What in the hell could possibly go wrong? I have to share some footage of an interview that I saw recently of Keith by CNBC within the last month, and they asked him a question about Obamacare, and we'll probably play it twice because I want you to pay attention to the facial expressions of both Keith when he's asked the question and of the interviewers when they get their answer.
Industry in this country. That's where I'd probably start.
So, Dr. Smith, let me just take that one step further. Earlier on this week, we met and spoke to the new CEO, the first CEO of Obamacare, Kevin Cunahan. If you were in his shoes and he's got, a lot of things to do ahead of him, what would be the first thing you would do to make Obamacare better?
I would resign. It's an impossible task. The central planners never get it right. There is no way that healthcare
you have to watch it
is going to
again.
get any better
It's
because
priceless.
there's more government. The government is the problem with healthcare rolls out to every other business and industry in this country. That's where I'd probably start.
So, Dr. Smith, let me just take that one step further. Earlier on this week, we met and spoke to the new CEO, the first CEO of Obamacare, Kevin Cunahan. If you were in his shoes and he's got, a lot of things to do ahead of him, what would be the first thing you would do to make Obamacare better?
I would resign. It's an impossible task. The central planners never get it right. There is
That
no
is the
way
best video
that healthcare
ever.
is going to get any better.
Keith sent me the link to that one night, and I'm still laughing. It's been what's it been, a month? It's priceless. The sad thing for Keith was he wasn't actually sitting there with them, obviously, so he couldn't see that until he actually saw the footage. So, in all seriousness, we all know that this was designed to fail, right? I mean, I just walked us through all the attempts for them to get to socialized medicine. As Reagan said, it's the foot in the door philosophy. Look who we're dealing with. They wanted socialized medicine. They still want socialized medicine. They knew they couldn't pull it off, so they put this bill together, passed it, and figured it would fail and that we would ultimately end up with what they wanted to begin with. We've seen government interventions and how well that works, and we collectively need to do what we can to turn things around and without an ulterior, greed-fed intention. And the Free Market Medical Association is a great example of that. It should be no surprise to anyone in this room that we can traverse the country to have any medical procedure performed, and the billed charges will be as diverse as the terrain itself. Speaking of terrain, there is not a mountain between Denver, Colorado, and Oklahoma City, not one. The billed charges for a gallbladder removal in Alabama could be $8,000, and it could be $50,000 in New York. And I, as a consumer, won't have any idea what the billed charges are going to be until I get that enigmatic EOB in the mail 3 months from now. And it makes absolutely no sense, and we can't stand for it any longer. A group of us, we were visiting D.C. The Consumer Union was brought up today, and it was a flattering comment, and I was scratching my head thinking, I didn't have a flattering meeting when I was there. There was a group of us in D.C., and I don't know if it was pre-Obamacare or post, but we went to the Consumer Union, and we had a meeting. I left the actual meeting room because when the lady said, this SBC that we all have to give to our employees is the greatest thing ever, I thought it would be best if I just walked out of the room. So I walked out of the room, and there was a whole wall of all the consumer reports, and I'm standing there thinking, this is insane. I can stand here all day today and shop for anything I want to and review cost and quality information till the cows come home, except for healthcare. There's going to be nothing in these books on healthcare. And that's kind of where we sit today for the most part. One slight step in the right direction would be for us as consumers and professionals to use the proper terminology and to become more engaged in the process. The cost of healthcare and billed charges are two different things, and we should not be using those terms interchangeably. A lot of people, and me included, I say, the cost of healthcare is our problem, and it's not the cost of healthcare. I mean, according to the folks in this room and what you're doing, the cost of healthcare is manageable. It's the billed charges that we have an issue with as employers that are sponsoring benefits for our employees. Employer-sponsored plans make up roughly 60% of the covered employees in the country, and the number's growing. For every TPA client that I have, they are busy. They are bringing on groups left and right. We need to focus on private sector reform, and the three essential components are right here in this room. We have providers, we have employers, and we have patients. And we simply need to spread the message and collaborate, which is why we're here today, and which is why I'm so happy. To a certain extent, throughout time, private sector reform has been trumping government efforts. Self-funding is growing, and we are figuring out how to deal with the regulations that we've been handed. Roughly 57% of U.S. workers are covered by traditional PPO plans. And people are always asking me if I'm anti-PPO. Is there any value in PPOs? Are they going to become obsolete? And I'm sure most of the time I sound anti-PPO. Last year, I got a call from the AAPPO, and I don't even really know what it stands, American Association of PPOs, asking if I would speak at their conference in California. And I thought, have you lost your mind? You want me to stand in front of your audience and speak? And really, there are a handful of PPOs out there that are wanting to do the right thing. And then we're left with the others that have been around for years. So the reality is I'm not anti-PPO. I'm anti, and I can't come up with a better word than scam. Don't get me wrong, there are a number of them that are doing the right thing. I have a few of them that are clients. And scam might not be the right word, but let me give you an example. When I was at the TPA, I had a claim come in from the East Coast for $1.4 million. It was an in-network claim, and a lot of people get excited when it's an in-network claim. I cringe. It's an in-network claim, $1.4 million with a 15% discount. Well, big deal. So I ignored the fact, to your question earlier, sir, I ignored the fact that I had a PPO contract, and I called the provider and said, we're not paying 15% off of 1.4. What are we going to do? And after many days and probably weeks of negotiating, at the end of the day, I had a letter of agreement between the plan and the facility to accept a little under $400,000 as paid in full. Now, they were making money still. They're happy. So why do we have to go through this process of calling them out on their claims that are outrageous? Maybe they needed to prove more charity care that year. I don't know. The best PPO analogy that I usually can come up with when I'm speaking is selling my house. So I'm going to sell you my house for a 50% discount. And I would think that you would ask me what the cost of my house is and why we don't do that in healthcare. I have no idea. We also get comps and we get an appraisal and we go through all these things to make sure that we're doing the right thing when we're purchasing our house, and yet we just push it aside when it comes to healthcare. We had a lot of talk earlier about quality, and I actually had a call from, it was a brokerage firm last week, asking, they knew I was going to be speaking here, and they were asking about quality. How do you know, if we're sending our employer groups to all these facilities, how do we know what their quality is? And I probably just let out a big sigh and wanted to say a few choice words, and then I said, well, let me ask you this. Show me the last report that you got from Multiplan explaining the quality of the providers that your members are going to. And he couldn't answer that because there is no such thing. So if we're moving in this direction, we're touting transparency, and the one thing that they're going to bring up is quality, but yet they're not requiring it on the other side. So we just have to hold firm and just keep marching forward. It's a lame argument. And as soon as, Multiplan's telling me the quality of my providers, then maybe we should do something different. And that's not going to happen. Many of the PPO contracts are so old and they're so passive They typically only benefit the provider and the PPO. Don't think they benefit the plan at all. The one selling feature, which is the threat that they hold over our head, is that it saves the member from balance billing. All that being said, there is value in what I've heard called the new age PPO, and really it's the old age PPO. But a percentage off of an unknown number is not going to cut it, folks, and we need to put our foot down. For 50% of the U.S. workers covered under PPO plans, I prefer a no-network option, a tiered plan, tiered networks, custom networks. Make them earn their money, make them bring value to the table, or don't have them at all. This 57% is an easy target market for the folks in this room, and they are getting robbed, and they need a solution. To address this ever-increasing problem, the industry is endeavoring to be innovative in an attempt to reduce the amount employers and patients are paying for health care. The California Public Employers Retirement System, typically referred to as CalPERS, evaluated the impact of reference-based pricing on the use and the prices for knee and hip replacements from 2008 to 2012, using enrollees in the Anthem Blue Cross Blue Shield as a comparison. In the first year after implementation, surgical volumes for CalPERS increased by 21.2% at the low-price facilities and decreased by 34.3% at the high-price facilities. Charges to CalPERS members declined by 5.6% at the low-price facilities and by 34% at the high-price facilities. In 2011 alone, reference-based pricing accounted for $2.8 million in savings for CalPERS and $0.3 million in lower cost sharing for its members. There are solutions out there besides the PPOs. Reference-based pricing and Medicare Plus plans are being touted as the solution to address the health care costs incurred by health plans across the country, and vendors are popping up like this is the golden ticket. Just touching briefly on Medicare Plus, I caution folks somewhat. If we have all of our plans in this country that are in compliance with the regulations and we're paying at Medicare Plus, haven't we just done exactly what they wanted us to do? I caution folks on heading in that direction. These discussions, reference-based pricing, cost plus, Medicare Plus, they do not come without confusion and without controversy. As for value, to partner with a vendor that is going to reprice your claims at some reference point, please make sure that these claims are not ultimately being negotiated in court. The approach taken needs to be solid, and we don't want self-funding being tied up in court. Every self-funded plan in the country should have alternate benefit language allowing members to travel to the facilities that are represented here today. I know I was supposed to talk about red lights and green lights, but my friend at Healthcare Blue Book, he had all the red lights and green lights. For me, everything should be a green light. There should be no reason that we should think that there's an obstacle that we can't overcome in getting to where we need to be as payers in this country. There's a lot of contractual issues that we have to deal with, but let's deal with them. You know, everybody's afraid to touch Multiplan. I'm not afraid to touch Multiplan. We need to be aggressive in changing how this country deals with the cost of health care, bill charges, and the payment methodologies by which we use. And folks, this does not require a village. It requires folks like you here today. Physicians, listen to me carefully, and I want you to remember these words, and I bet I've said this to Keith 1,000 times. We need you, you do not need us. Seriously, we need you, you do not need us. You will get calls from folks trying to turn your delivery model into something different so that they can tack on a fee. I had a conversation with Keith not too long ago. A gentleman had approached him, and really what this gentleman wanted to do, he wanted to hijack Keith's claims and send them in under his cover. I'm like, seriously, are you kidding me? What are you going to, now you're ruining transparency. I have no room for you in my life, go away. He's probably here today, I'll buy you a drink. But I'm still not letting you do it. Employers and patients need to do their part in the new era of private sector reform. Employers, I want you to remember these words. Only pay for value and educate your employees. Are you really paying a PEPM to a broker that does nothing more than take the reports that he gets from the TPA and forward them on to you? Seriously? You can save a lot of money right there. Are you really paying claims at a percentage off of an unknown amount? If so, I will sell you my house. Are you really paying as high as 30% to someone to reprice your claims to what should be a reasonable amount to begin with, instead of addressing the underlying issue? We got to stop doing stupid things, is really what it boils down to. Only pay for true value and educate your employees. Incentivize the employees. Let's start with the basics. Let's teach them how to read an EOB. Many of your employees don't know how to read EOBs. They could be your first line of defense for fraud. There are many employers out there that are teaching their employees how to read an EOB, and if they discover something that shouldn't be there, they're giving them cash and saying, thank you for catching that because I wouldn't have caught it. I drafted last month a plan for a California employer to allow their employees to travel to Oklahoma or to Virginia to receive treatment at transparent facilities. If those it's not required, if they choose to do so, there's no deductible, there's no out-of-pocket. All expenses are paid for the employee and a companion, and they're putting $1,500 in that employee's pocket if they do it. And they're going to be dollars ahead every time. These are the things that we need to start doing to get their attention. Amend your plan documents. For an employee that has a very rich plan offering, why would they care? Why would they do anything different? In April, a cousin of mine who's been deaf for over 40 years went to the East Coast, a teaching facility, and had a cochlear implant put in his ear so that he could hear for the first time in 40 years. He called me wanting me to read his plan. It was open enrollment. He's on the federal government plan, the one that's exempt from Obamacare. He wanted me to read all the plans that he had available to him and let him have the best deal. And I was fuming by the time I was done reading these plans because it didn't matter which one he picked. He has, let me get the numbers. I think he had a $1,900 out-of-pocket max. He had no deductible, and he could go anywhere he wanted. He could have gone to the Surgery Center of Oklahoma, and correct me if I'm wrong, at the time, it was $8,800, plus the cost of the actual implant. No upcharge, just the cost of the actual implant. And instead his bills came in at about $75,000. Now for my cousin, why would he do that? Why would he bother? This is a federal government plan, and they're clueless that this was an option, nor would they ever seek out to require such an activity. So we need to make sure we're paying for value, that our employees are educated, and that our plan language supports what we're willing to pay for. Tomorrow, my dear friend Adam, who just joined us recently, is going to walk you through some plan language to help you implement some of these exciting changes. And again, I thank you for allowing me to be here today, and I thank you for doing what you do. Does anybody have any questions? I'm so worried about getting up and down those stairs.
Here you go.
What are some of the upcoming major legal hurdles that we all face as trying to run a price-transparent healthcare model?
The legal hurdles for transparency? I mean, really, the biggest issue that you have is, from an employer perspective, is dealing with the contracts. And, yeah, the PPO contracts and understanding who they're between. Some of them have to be unearthed because they haven't been read in years, and people won't be able to find them. It's quite the process. But from an employer standpoint, the biggest obstacle is typically the PPO contracts. And if you have a PPO contract that's restrictive and says you're not allowed to do these, we talked about it earlier, treat it as an out-of-network benefit. But if you have a bad contract, regardless, tell them that you want a better contract. And sometimes we have to walk away from these people if there's no value there. Yeah.
How would you define Multiplan, or would you just give a synopsis of what you mean by Multiplan?
Oh, Multiplan is one of the largest PPOs in the country. So they've purchased up I don't even know the history, but they've purchased up many of the PPOs in the country, and they are the elephant. Anybody else?
As a provider, I can tell you that doctors are really afraid to go there because they're being told if doctors talk about prices to each other, they're violating Stark and RICO laws. If, say, someone in a restaurant that wants to provide health care for their employees sends their patients to me and pays me directly, then I'm liable to be accused of being an insurance company, and I fall under the insurance laws. So it's, and again, I know that's state by state probably, but the biggest thing is there's a lot of fear that if we start sticking our neck into this, we will get hammered and maybe even go to jail. So could you address that?
Well, I'll bail you out. I mean, I guess there's an argument for, if you're colluding on prices and, fixing the market price, that's one thing. But if you're posting your prices on your website, I mean, you're not violating anything.
No, but if you have a doctor who's contracting with an insurance company, if two doctors get together and say, I think Anthem's screwing us, they give us this price for this, what did they give you? Then in theory, you're racketeering.
Well, actually, in theory, you're violating your contract because most of the PPO contracts have a confidentiality provision. Provider, they don't want anybody to know what they're accepting.
So my point is, it's, for a lot of providers that would like to do this, there's a lot of fear.
Yeah. Oh, I understand.
If I could just expand on that, I'm also a direct primary care provider as well. And our legal counsel, basically, when we were sort of working this out, working with businesses, is basically looking back at ERISA and saying, if we take pre-tax dollars from an employer for healthcare services, by definition, we become a group health plan. And as a group health plan, you are then subject to all the laws under ERISA and the Affordable Care Act. Does that sound?
That is true.
So, as a provider, it gets a little bit scary when you go to engage with an employer to accept money from an employer to take care of their employees. Otherwise, you will potentially be regulated as an insurance plan, basically. You are as a group health plan. If you take the pre-tax dollars, you are defined under ERISA as a group health plan.
If the employer is taking money from their employees on a pre-tax basis, typically they're going to fall under an ERISA umbrella. That has no impact on you as a provider treating the patients under an ERISA health plan. That's no different whether you're signed up with the PPO with Multiplan or you're a standalone independent physician. You treating those patients has no impact.
Okay. And to the one point about the being accused of being an illegal insurance plan, we've been accused of being an illegal insurance plan because we charge a flat per member per month price. And in fact, one of the large physician organizations in the country sort of threatened to shut us down as a result of that. And I'm going to talk more about that in my talk tomorrow, but we are passing legislation state by state, going state by state. We just got something out of committee in Michigan just this week declaring that direct primary care relationships and retainer agreements are not insurance programs. So we're going state by state and trying to make this happen.
I don't have the ability to provide this, but I think one of the things that would help this group and many more providers across the country is some way to help them resolve those types of legal questions. Some of them are unfounded. Some of them may have some merit, but there may be a way around it. But to find legal expertise in this arena it's hard to find, and if we could get some and share it, that would be a great step forward, I think.
I'm happy to help facilitate that. Anything I can do to double the size of this room next year, I'm happy to do.
In this room right now, there's some tremendous resource right in that area, right here in this room. Two of them are speaking. One of them's up there and one's speaking tomorrow.
Cori, doesn't the ACA, it mentions direct primary care. The ACA mentions direct primary care. Doesn't it
explicitly state that it is not an insurance product and that it's allowed to participate? I mean, I've read the clause. I can't cite it to you, but that is it. 1301. That's it. Who said that?
And what's
Yeah.
it say?
It basically, 1301A3 basically says that two things. If you have a direct primary care practice coupled with a qualified plan, then it is absolutely legal for the act. But it, you can still have a direct primary care practice, but those two components, if you have insurance and a DPC clinic, then completely legit.
Guys with code sections, they know them by heart.
Thank you so much for your clear presentation. And just recently, the AAPS had their meeting, and I had a chance to meet a gentleman from the FTC. And he is very friendly to free market. And he's very welcoming anybody's concerns. And I spent at least 2 hours with him. And I was surprised. I was truly surprised. So if anything that is anti-competitive, they will hammer you. But what we're doing is not anti-competitive. It's pro-competitive. And I asked him specifically about that. So, so rest assured.
The FTC's too worried about those dialysis clinics. They think we're heroes compared to that scam. Anybody else?
Can you read your one-sentence description of Obamacare? And can I quote?
I'll email it to you. There's actually a video that goes with that, and I think, it was so long ago that I came across it, and I think it's a little gal that's about this tall, and I think she's a nun and a doctor, and she's got an accent, and she just rattles it off, and it was, at the time, it was as funny as the Google Eye video of Keith and the interviewers, but I'll send it to you. Anybody else? Thank you so much.
Thank you.